Mr. Chairman, Dr. Kojak, Dr. Kabudi, dear colleagues, I would like first to thank once again for the privilege of being here at this meeting and experiencing again the fantastic Turkish hospitality. Thank you so much. I've been given the task to talk a little about our failures. The parathyroid operated patients who need another operation. And I'll be talking about patients not with general neck surgery from before, but only patients with previous parathyroid surgery. In some of the papers about the reoperative surgery, the first operation was a thyroid operation. So the first we have to ask ourselves when we have a patient with a recurrency is if it has been persistent since the first operation or a true recurrence coming more than 6 months after the primary operation. Could it be a malignant sign of malignancy, a parathyroid cancer? Was the first diagnosis complete and what is correct? We are using a new round of tests for familial hypocalciuric hypercalcemia, FHH, because we have families along the Norwegian coast with this disease and it's difficult to sort out from HPT. And if we do the calcium excretion in the urine once more, 24-hour calcium excretion, and we do the DNA sequencing of the calcium receptor if necessary, and it has not been done before. And in young patients, we think of multiple endocrine neoplasias, and with a family history, we will do a DNA sequencing of the MEN1 gene and the RET gene, according to the family history. Could it be sarcoidosis or secondary HPT like vitamin D insufficiency, which is not rare in Norway? And if we find the diagnosis correct, we must have a stronger indication to reopen the neck, maybe stronger than the first time. Our small material consists of 51 patients over almost 20 years. So this material is far too small to make any general conclusions regarding the treatment and the examinations, but I will use it as an example or an origo for making some comments. 41 of the patients were referred from other hospitals in Norway, and 10 patients came from our own department. Those 10 represented less than 1% of our HPT operations during those years. And as in most materials, nearly all had persistent HPT when it come to analysis. 3 had a recurrent HPT. 2 of them were papillary thyroid carcinoma, and they were reoperated and they are normal calcemic more than 6 years out. Those 51 patients, 11 of them needed 2 operations to correct the disease, and we have 1 patient who is not yet cured for her disease. I'll come back to that. We found mostly adenomas, solitary parathyroid adenomas, 39, double adenomas, 4, hyperplasia, 6, and the 2 carcinomas. And as you can see, the glands were fairly large with a normal weight between 30 and 50 milligrams. We had a median weight of 580 milligrams. The 17 milligram parathyroid that we have here registered here is registered in the papers like 17 milligrams, but I don't think that is correct actually. This is a typical adenoma. Maybe you can see the small rim of normal parathyroid tissue in the periphery of the adenoma, single adenoma, and that was the only gland enlarged in this patient. It's very easy. This picture is meant to remind us all about how asymmetric hyperplasia can be. Multiglandular parathyroid disease is very often asymmetrical, and this patient had two upper large ones, two lower, slightly moderately enlarged. This is what we removed, and there is a remnant here of about 50 milligrams, and a number 5 gland as well. And when we are talking about reoperations for parathyroid disease, we should also remember that about 13% from the old classic Swedish material by Åkerström, about 13% have more than 4 parathyroid glands in Opta-C material. So, 95%, 48 of our 51% are normal calcemic, including the 2 carcinomas as I mentioned. So there is a cure rate of 95% after more than 60 operations. 3 have persistent hypercalcemia, 1 with FHH. Primary diagnosis we made were wrong, and she should not have been operated. 1 had a multiglandular disease in tertiary HPT, a renal transplant patient. And 1 primary HPT is still not cured after 2 reoperations. Now we've found the remaining adenoma, but she does not want a 3rd operation right now. More surgical details. Most of the patients were operated through the neck incision, and most of them were operated with a posterior excess, that is between the strap muscle and the sternocleidomastoid. And it is often of good help to divide the omohyoid muscle just to open the lateral space, which is in many cases not operated in at the first operation. Complications: we have 1 accidental unilateral vocal cord paresis, permanent, and a non-fatal thromboembolic complication. So, what must we do before embarking on a reoperation for hyperparathyroidism? It is very important to receive and to read thoroughly the operative notes from the previous operation, 1 or more, and likewise to read the histology reports. And before reoperation, we will always do an ultrasonography of the whole neck, not only the parathyroid or the thyroid region itself. And if we are in doubt, we will make a fine needle aspiration and determine PTH in that aspirate, like a biochemical or functional confirmation. Sestamibi scintigraphy, nowadays with SPECT CT, are also used in all patients, and they were used in, but not in the material I'm going to refer to. If there is positive scintigraphy, for example, in the thorax, where we cannot access the lesion with the ultrasound, we will do a CT with contrast or an MRI with contrast. The best PET CT or the best PET substance for parathyroids seem to be C11-methionine as a marker. We do not have that possibility in Bergen or in Norway at all, so we have sent a few patients to Austria and to Uppsala in Sweden to have the PET with C11-methionine determined. Among invasive localizing techniques, we have used venography with PTH determination and a very few cases of arteriography. So, the material of 51 patients will show examples that in our institution we did not start with routine pre-op localization before the first operation until the early 2000s. We thought that we should spare money but has later come to that it is cost effective to do localizing studies before the first operation, and we do routinely ultrasound in the neck and a SESTA-MEB scan nowadays. And ultrasonography, this is the presentation of an intrathyroidal parathyroid gland. Most of the intrathyroidal glands are actually not true intrathyroidal. They have usually an opening to the free air, and it can be enucleated. But this one was called truly intraoperative. It was covered by thyroid tissue also in the whole surrounding. Scintigraphy, these are from the years where we used the subtraction scintigraphy, technetium and MEB. Nowadays we do as dynamic scint with only one isotope. CT is better than we often think when it comes to demonstrating parathyroid lesions in the thoracic cage, in the mediastinum, and they can be clearly demonstrated, presented like this parathyroid that was difficult to find because of previous scar tissue. And briefly about venous sampling, we want to sample blood from each side of the thyroid and determine PTH hormone, so we know which side to look for the hyperfunctioning parathyroid. And there is the normal anatomy makes it possible to do that. But what is more important is that there is usually a very distinct thymic vein that is not on this slide. I think it could have been this that is the thymic vein. It often enters the subclavian or the brachiocephalic vein from behind. But the radiologist should always try to enter that vein if we suspect parathyroid adenoma in the thymus. And we also have demonstrated the map where each sample were taken from. And I'm sure many of you use this method, and we find the highest production of parathyroid hormone, in this case from the lower right thyroid side, and there is also a little higher value in the cava superior, longer, nearer to the heart. So a couple of times we have used arteriography, and it may be difficult to see here, but this is a parathyroid adenoma that was not demonstrated to us until we had this arteriogram. If there is scintigraphy uptake in the thorax that we cannot reach with ultrasound, we must do a CT and a CT SPECT, hopefully. And we see here a lesion that is also functionally active by scintigraphy. This is a lesion in the aortopulmonal window. You can see the two branches of the bronchi dividing from the trachea here. And we had two of those cases. We have more earlier, but we had two of these cases in a few weeks' time. And did the neck operation without knowing anything about the chest or the mediastinum. But these were done before reoperation, and those two cases was substantial impact to start doing more routine examinations before embarking on the first operations, as mentioned. These two adenomas of several grams each were removed through the pericard and sternotomy and through the pericard. We did not dare to try thoracoscopic access, but I know that some will do that. So, before going to the reoperation, and without doing too many examinations, if we have two concordant non-invasive studies, that is important if it fits with what is thought by reading the operative note from the previous surgeon. If not, we must do the additional techniques that we mentioned. And if you suspect an adenoma case as a reason for the reoperation, the surgeon must know exact localization of the adenoma before starting the operation. In multiglandular disease, it's much more difficult, and we must plan or usually a bilateral open reoperation and look for the glands that do often not show on either scintigraphy or ultrasound. Your ultrasound and MIBI was done in nearly all 51 patients, and that examination was very good in our hospital. We have active, eager radiologists, and they found a solution in more than half of the patients. That was the venous sampling, 25 or 26 on the correct side, and the ultrasound and MIBI was 55%, and that is not so good a figure. It's partly because it's stemming many years back before the training in ultrasonography was as good as it is nowadays. In 3 patients, scintigraphy led us on astray, and there was also one venous sampling that was on the wrong side that complicated the operation. So before going more into the reoperations, how can we avoid some of the reoperations that we will see in the results in our study that we should have avoided? And how experienced is the surgeon doing the primary operation? In reality, the experience is varying, but one should aim at the most senior surgeon in parathyroid experience should be nearby at least when there are HPT operations going on. And what do we do if it is unexpectedly difficult? Either we are trained by long experience or younger in the business. We must not be afraid to ask for assistance. It may solve the problems to have a colleague with fresh mind and fresh eyes and to come and look over the field instead of digging oneself deeper and deeper into non-functioning surgery. Take a break, have a cup of coffee, and start again with fresh mind, because it's very tedious and very disappointing and mentally straining to look for the missing link in parathyroid operations. How can we better the by other means. We can use intraoperative PTH. In this case, we had the information that on the right side there was a large parathyroid with nothing was seen on the upper right side. We did the operation, found a large 500 milligrams parathyroid, and saw a normal upper right side, and closed the wound, and then got the answers a few minutes later that there was a fall of from 18 to 8 picomoles per liter. That is not that is more than 50%, but that is not enough. Normal range is down here. And then we opened the left-hand side, opened the wound again, explored the left-hand side, and found 2 large lesions that were removed from the left side. This is a typical patient where we are saved by intraoperative PTH. I guess you will hear more about that from the next speaker. And oftentimes intraoperative PTH is a luxury and a confirmation of what is done, but in cases like this, it's complete determining the result. I will also mention lithium-induced HPT. Lithium use for long-term psychic diseases, and we see that's not so rare. Lithium-induced HPT and lithium-induced goiter. And recently there was a report on long-term results of surgery after lithium-associated HPT from south of Sweden that is much larger and with a follow-up much longer than the previous studies. And they were disappointed by the results because at the time of follow-up they had persistent or recurrent HPT in 42% of the material. And the main message in that article is also that the multiglandular disease is very asymmetric, so it's easy to be impressed by only the largest one of the glands. So in lithium patients, we must be active with what we can see, or the size and the form and the color of the parathyroid, and we must do the intraoperative PTH. But it's very easy also to remove too much parathyroid tissue in multiglandular disease, and hypoparathyroidism needing treatment is probably much more a problem for the patient than a slight hyperparathyroidism. In men 1 cases, we have done not total parathyroidectomy and implantation in the arm, because that is a very heavy burden on the patient, especially in the first month. So we have suggested to the patient that we do a stepwise operation for men and plan a reoperation that may be necessary in 5 or in 10 or in 15 years. We recently operated one who had the subtotal 12 years ago and another 6 years ago, and they are prepared to have a new operation after that time, and they avoid the risk of morbidity from hypoparathyroidism for many years. In men 2, where hyperparathyroidism is not so active usually as like in men 1, it's like in the lithium cases. Start with the largest one and see what you have obtained by doing intraoperative PTH. And the familial non-men HPT, it's without any specific knowledge about that. You must do the best you can from the size and intraoperative PTH. The same in tertiary HPT, the patient with a well-functioning renal transplant who has had secondary HPT and now after transplantation the high PTH secretion continues. In those cases, we did total parathyroidectomy to avoid reoperations, but since many years now have been doing subtotal, it is much milder for the patient and easier for the nephrologist to handle also. Cryopreservation of tissue. If you think you are operating and removing the last parathyroid in a multi-series of operations, you should consider cryopreservation. But that is practically very difficult many times. It's rare, and if there is not a routine for it, it's easy to lose the tissue because it must be frozen in stepwise manner and with the different types of media. So if you feel it's time for total thyroidectomy or in a reoperation, one solution is to do a little extra transplant in the brachioradialis arm and be prepared to remove one or two of them in local anesthesia later on. So, when it comes to the results, what were the reasons for the need for a second or third operation in our patients? Actually, the reason was mainly surgical, due to the surgeon. There were few true dislocations of localization of the parathyroid glands, and most of the dislocations were actually expectable because if you knew the literature of where to find the normal areas for the parathyroids. And we did, in our department, too little of routine localization before the primary operation, especially in the intrathoracic cases, as I have already said. So cryopreservation, we do it, but we have never used it, and that is the case also in the literature, that most people think that is tedious and difficult. So, these are the location where we found the reason for 51 patients needing a reoperation for HPT. And those marked in black are thought to be upper area, and those blue are the lower glands. I stands for intraoperative, intrathyroidal, 3 that we thought was completely covered by thyroid tissue. The easiest glands to overlook is the upper one, who has a normal origo, but runs behind and along the esophagus on the columna or on the prevertebral fascia. I'll come back to that a little later. And the upper glands are coming from the 4th branchial pouch and have often a short distance to travel. The lower glands are coming from the 3rd branchial pouch and have a long way to travel, and they develop in embryonic life. They develop together with the thymus and sometimes follow the thymus all the way down to the aortopulmonary window. But oftentimes the lower glands within the thymus can be reached from the neck. These 2 glands, this one and this one, we think represent upper glands actually, even though they are blue. The upper glands, they are starting at the 3rd pouch, but they belong to the lower group and have a long way to study, to go. And they can be found close to the carotid artery, like here and here, lateral to the carotid artery and lateral to the carotid artery. They also may be located inside the vagus nerve. I have never seen that, but that has been reported. And it is also thought that the parathyroids that follow all the way to the mid-mediastinum are embryonically dependent or influenced by the vagus nerve. So, this is a normal gland. This is up and this is down, recurrent nerve, inferior thyroid artery, and this is the upper left parathyroid gland. When the upper gland enlarges and it becomes heavy probably, and it usually goes behind the artery and sometimes also behind the nerve, and it can be found on the lateral wall of esophagus, on the prevertebral fascia. And that is the most common single aberration, which is actually not an aberration because the origo of the gland is in the right place. And if there is any difficulty in finding the upper parathyroid, one should clearly see the esophagus and the vertebra. And this is an example of such an enlarged upper left gland that is going down. The origo is up here, and it is going down along the esophagus on the medial side of the nerve, and the artery has been divided. And freeing them are sometimes dangerous for the nerve, but it can be done. This was the reason for the local anesthesia in this patient was that she had an Eisenmenger syndrome, and the anesthesiologist would not give her general anesthesia at that time. But it's incredible how little local anesthesia is necessary for parathyroid surgery, and that was one of the first we did. But that's a typical first place to look. If you miss an upper gland, look along the esophagus. And that's why this should be the last slide I'm going to show. If you remember something from this lecture, you should at least remember the location of the upper glands and the lower glands and the lateral ones. Those are truly dislocated, but most of the parathyroids are localized in an area where it is a bit out of order, but according to embryology and according to experience, you will find them. Most of the reasons for the operation is in these areas. We did 6 sternotomies. Nowadays we'll do the thoracic or mediastinal glands thoracoscopically, but not the ones in the aortopulmonary window. This is a much cited expression from Dr. Cope in the United States many years ago, and that is the reason that even though a patient may be scheduled for a 3/4 of an hour, if it is really difficult, unexpectedly difficult to find the lesion and solve the problem at the first operation, you should use time, re-administer the day, and use the time you need to try to solve the problem instead of closing and come back later if you can avoid. Thank you very much.